So my topic is very basic topic. So usually we don't seldom ask you in exam for clinical, but sometimes we ask mainly during Viva. Okay. So I hope you all can, because after this lecture I will give another lecture also on congenital scoliosis. Okay. So if you look at the anatomy of the spinal cord, I think this one is only a revision. So usually start at below the medulla oblongata, and then if let's say in adults and between lower border of L1, also in pediatric maybe goes down up to L2, L3. Because let's say like what we learned yesterday, because if let's say you have to differentiate either the lesion is at the spinal cord, or the lesion is at the conus, or the lesion is at the corda equina. So if let's say if the lesion is something inside the infection, trauma, or malignancy is at the cord, so mainly you have symptoms of upper motor. If let's say you have a lesion at the conus medullaris, so you will have a symptom of mixed symptom between upper motor and lower motor, and sometimes it's very difficult for you to differentiate either this one is lower motor or upper motor. And then if let's say you have a lesion at the corda equina, you will have symptoms of lower motor neuron lesion. Okay, so that one is a very basic facts. So that's why you have to know. So let's talk about spinal cord injury today. So if you look at the spinal cord epidemiology, so this is the data from Hospital Kuala Lumpur. So you will see this one is this later the journal published in 2013. So if you look at the epidemiology from 292 patients, so you will see from the demographic data mainly the causes of spinal cord injury in our country is motor vehicle accident, and then followed by fall, and then if you see most of them are male patient compared to female patient, and then you will see some of them present with either with quadriplegia, or and then some of them present with paraplegia. Okay, so you look at the level of injury. So you see the level of injury here. You see commonest level is at the from C1 to C7. So it means at the cervical spine. If you injury of the cervical spine, is very common for you to have a cervical cord injury from trauma, but you can see also injury at the thoracic area. So thoracic area. So what type of injury? So you see here is mainly from this journal, you see as fracture dislocation. So you see fracture dislocation is very common, followed by burst fracture, and then other type of fracture. Okay. So in our practice, so most of the time you see patient is a burst fracture, but the commonest is fracture dislocation. So when we talk about spinal cord injury, they talk about primary injury and secondary injury. So how do you differentiate between primary injury and secondary injury? So primary injury, what I see is you can prevent this primary injury with education, but secondary injury usually you cannot prevent because this one is at the cell level. So that's why most of the R&D involved for the secondary injury, not for the primary injury. So primary injury, why I say because of education, mostly you can see now the government has reduced how you use the seat belts at the back of the car, and then you have to wear helmet. If you see education also how the MotoGP and the VC F1, and before this they only wear helmet. Now they say they also use support at the neck to prevent neck injury, to prevent spinal cord injury. That one is come with education. Okay, it's not come with because that one you can prevent. Okay, secondary spinal cord injury you cannot prevent because there is process at the cell level. So that's why now there is still no drugs that can treat spinal cord injury. If let's say you have a drug that can treat patient with spinal cord injury, definitely you will win a Nobel Prize. Because even though there are a lot of experimental study done, but until today there is no such drug miracle that can treat patient with spinal cord injury. Okay. So what is actually the primary injury? So primary injury is a injury that occurs at the time of injury. Meaning insult occurs at the time of injury. It can be stretch, contusion, laceration, something like that. Okay. So example, fracture dislocation. Primary injury will trigger secondary injury as well. So this is a secondary injury. It means it's a process when you have a primary injury, so it will follow by secondary injury. So if there is a disruption of the microvascular causes hemorrhage, edema, and then it will impair further perfusion, and this all the process will lead into a process at the cell level where it goes into ischemia and necrosis. So it's not only occurs a local effect, but the systemic effect also contribute to the injury of the spinal cord level, because this local effect will further exacerbate by your punya respiratory and CVS function. It means also it depends, let's say you have an injury to your chest, your inspiratory, expiratory muscle also will be minimal oxygen will deliver to your tissue, and then systemic hypotension, hypoxemia cause further neuronal damage. So that's why very important. So what I want to say here, what is important is your resuscitation. Because if let's say you have a patient with spinal cord injury, how you resuscitate the patient? No. Because that one will determine either how bad is the patient to be have your spinal cord injury. Okay, so you look at this diagram. So you see your primary injury and your secondary injury. So you can see immediate, acute, early acute, and start acute. You can see hemorrhage. In early acute, you can see ischemia, and then later in subacute, you can see macrophage infiltration. So this one occurs at the cell level. So this one is reversible when how you see the patient. How you see the patient, and that one will cause later. What is the role of resuscitation? How you do resuscitation? What is the role of steroid? And then what is the role of decompression later? So that's why what is important is your resuscitation. So how we see the patient? So most of the time when you see the patient, that's why you see the patient in the casualty. You see the patient will take history, and then history will tell you either the patient can move upper limb, can move the lower limb, or not. Patient either can partially move, there is no bowel and bladder function. And after that, you do your general examination, followed by spinal examination, and then you do your neurological examination of the upper limb and lower limb. Okay. So this is mainly main or your myotome and dermatome. So you have to know how to examine the patient. And then, what is the clinical evaluation? What happened to the patient? Because once after you evaluate the patient, you want to know either the patient is in spinal shock or the patient is in neurogenic shock. So that's why then the patient most of the time occurs in the casualty. So you as a doctor, we have to know whether the patient is spinal shock or the patient is in neurogenic shock. So what is the difference between spinal shock and what is the difference of neurogenic shock? So what is spinal shock? So definition of spinal shock is a spinal cord nervous tissue disruption, mainly on physiological disturbance rather than mechanical insult. So it means during this time of injury, there will be no motor sensory reflexes below the level of injury. So you examine the patient, so there will be all sensory motor reflexes will be absent. Okay, so how does this resolve? So some say up to 72 hours. So there is a bulbocavernosus reflex. The local reflex represent a local reflex S3, S4. So when this reflex already come back, so you know your spinal shock is already end. So once your spinal shock already end, you examine again the patient. Now you can determine either this one the injury will be complete or incomplete injury. Okay, so that's how you know either the complete or incomplete. If let's say the patient has some preservations of the distally, either your voluntary rectal motor function, perianal sensation, or rectoflexion activity, what they say about sacral sparing, so it means the injury is incomplete. If let's say the patient does not have all these three, you examine the patient and means the injury is complete. Okay, so that's how you determine the patient. Okay. So what I want to say here, what type of incomplete spinal cord injury? Okay, so here I think Dr. Zairo will talk, Mr. Zairo will talk on central cord syndrome, which is very common. So here you can see anterior cord, Brownlee cord, and posterior cord syndrome. Okay, so but the commonest is the central cord. With central cord, I think where the injury occurs mainly in elderly with hyperextension injury, where the upper limb will be affected more than the lower limb. This kind of patient will see more in the ward rather than other patients. I seldom see anterior cord, posterior cord, or Brownlee cord. Understand? Maybe in my practice, I see one or two patients with Brownlee cord, but not common. Most of them come with central cord syndrome. Okay. So why is neurogenic shock? So once the patient have also occurs, the patient have a spinal shock at the same time because of when you have injury above the T5, because there is a sympathetic change, there is a loss of the injury to sympathetic change, so that's why your parasympathetic become dominant. So there will be hypotension, unopposed vagal parasympathetic, there will be vasodilatation, and then cause hypovolemic and hypotension. So patient also will be bradycardia. So that's why you will see some of the patient when they admit to the casualties, then they are in the state of hypotensive and bradycardia. So that's why you have to see either this one, a patient with spinal cord injury, they are in the state of hypovolemic shock, or they are in state of neurogenic shock. So that's why we as a doctor, we have to differentiate which one is which. And some of the patient at the same time also, they can develop spinal shock. So this is how we differentiate between spinal shock and neurogenic shock. So how do you differentiate? So if you look at this diagram, you see the definition of spinal shock is immediate temporary loss of total power, sensation and reflexes below the level of injury, and then neurogenic shock is sudden loss of sympathetic nervous system signal. So if you see this diagram, so you will see how is the difference. Okay. Next diagram also you can see there's a difference between neurogenic shock and hypovolemic shock. This one because some of the patient, if let's say the patient are in the state of hypovolemic shock, we have to treat patient accordingly because the treatment is different. Okay, so this is clinical evaluation. You do a CT X-ray, CT scan, MRI based on what is indicated for the patient. I'm not going to discuss on it, but I want to discuss about acute medical treatment. So the primary focus is to optimize the tissue oxygenation and perfusion to counter the effect of secondary spinal cord injury. So that's why I think resuscitation is very important. Number 1, avoid hypotension. Number 2, induction of hypertension. Number 3, close ICU monitoring. And 4, early transfer to center for decompression. So this is number 1, airway protection and ventilation. Number 2, so the guidelines here shows that maintaining mean arterial pressure at least 85 to 90, adequate fluid resuscitation, transfusion, and vasopressor is very important. How to maintain your MAP up to 85 to 90 in order to prevent secondary spinal cord injury. So what is the role of corticosteroid? Some surgeon give, some surgeon does not give. Okay, so this one we have a long debate before this. If let's say you follow MSX webinar, so there's I think last year we discussed this a lot during the webinar, and then because one of the cases present is patient got spinal cord injury, so I just follow what is the paper by McFarlane. So the paper is presented in 2017. So he said that number 1, we suggest not offering a 24-hour infusion high dose of methylprednisolone to adult patient who present after 8 hours. I mean, if you present after 8 hours, not recommended. Okay, number 2, he say we suggest a 24-hour infusion high-dose methylprednisolone offered to patient within 8 hours of acute spinal cord injury as a treatment option. So it's not mandatory. Understand or not? It's not mandatory. If let's say you find that patient will benefit from your methylprednisolone, high-dose methylprednisolone, so you can give. But I think it's differ from center to center. My center, because some of the patient, they come after 8 hours. So most of the time we don't give methylprednisolone. Okay, but if let's say in Kuala Lumpur, I don't know other center where they come early. Maybe this one, if a young patient and you see patient come in complete neurology, maybe it will benefit for the patient. Then it's not wrong to give, but you have to monitor the patient. If let's say you give, it's not wrong, but it's the treatment option. Okay, Okay, number 3, they say we suggest not offering a 48-hour infusion high-dose methylprednisolone to adult patient with acute spinal cord injury. So the role of this, I think, paper by McFarlane, if let's say is during 8 hours, you can give. Okay, if you ask me my opinion, if let's say it's enter my center, within 8 hours, I will give them. Okay. So others are prevention of thromboembolic disease, how you use mechanical prophylaxis, and then timing for spinal cord decompression. So this one is still debatable, either you want to do early or you want to do late. So it depends on the class. So if you look at this diagram, so they will see either standard, guideline and option. So they say if you look at the class 3 evidence, decompression, reasonable practice, acute spinal cord injury, when possible recommended, urgent decompression within 24 hours. So the last word they say, early surgery reduce length of stay and might reduce post-injury medical complication. So if you others rehabilitation, so the conclusion number one, basic science studies show that the effect of trauma on soft tissue are resistant but require time to achieve maximum damage. Mental prednisolone is benefit for patient within 8 hours. Number three, early decompression is visible and can safely be performed. Okay, thank you.